This case of invasive fungal sinusitis was interpreted by a total of 197 residents, with the most frequently occurring score being a 1 out of 10 and an overall mean score of 3.05 out of 10. Overall, the average number of points lost out of 10 to observational discipline was 6.02. At the same time, 0.88 points were lost due to interpretive errors on the part of the residents. We define an effective report to be one that achieves scores between 7 and 10. In terms of letter grades, this would be A or B. In this most missed case, 21% of residents produced effective reports. We define a report having a critical error to be one with scores between 0 and 2. In terms of letter grades, this would be F or D. In this most missed case, 73% of residents produced reports with critical errors.
This patient presented from the bone marrow transplant unit with a neutropenic fever and sinus pain with clinical suspicion of invasive fungal sinus disease, but the disease was not definitive by clinical evaluation. In these patients, we screen with a non-contrast CT study, and this is the multiplanar reformation of that study. The analysis of this case should follow a logical pattern, evaluation of certain anatomic structures. Beginning from the top of the ethmoids and panning inferiorly, the first checkpoint going from superior to inferior is the preseptal soft tissues in the region of the lacrimal sac, which are too prominent on this side compared to the other. And there is a suggestion of some bone loss at the junction of the lacrimal bone and anterior aspect of the ethmoid bone. That abnormality or difference within the lacrimal sac region seems to persist, and as we go inferiorly, the preseptal soft tissue swelling thins out a little bit. The next checkpoint is the fat pad in front of the maxillary sinus, seen here underneath the superficial musculoaponeurotic system. That's clear, the branches of the infraorbital neurovascular bundles being seen, as well as the fat pad posterior to the maxillary sinus, which in this patient is abnormal on this side compared to that, so that there is strong evidence that this disease in the maxillary sinus has filtered through the posterior wall of the maxillary sinus, leaving the bone intact, spreading likely along the posterior superior alveolar vessels. The next checkpoint on the sagittal images also includes the pterygopalatine fossa, which in this case appears to be obliterated on that side, compared to the other side, sphenopalatine foramen, some distal branches of the maxillary artery there, but clearly infiltration of the pterygopalatine fossa by way of the sphenopalatine foramen, another checkpoint in the search pattern on the axial views, and the last checkpoint being the nasopharynx, with a possible suggestion of fullness in the nasopharynx on the right side compared to the left, although not clearly definitive. We switch to the coronal views then to evaluate the same areas, and we can begin with the area of the lacrimal sac, which appears more prominent on the right side compared to the left. Moving posteriorly, a careful look at the extraconal fat along the orbital floor, which in this patient is clear, and then more posteriorly a confirmatory look at the pterygopalatine fossa on the right, clearly infiltrated on the right compared to the normal fat pad on the left side. Moving more posteriorly, there is again some prominence on the right side of the nasopharynx, but no clear evidence of deep infiltration of the parapharyngeal space to confirm nasopharyngeal involvement, period. The nasal cavity disease in this patient is nonspecific. It is unilateral, which favors a invasive fungal sinusitis or rhinosinusitis diagnosis, but it's not definitive, but it is a favored pattern. There's no clear evidence of ulceration of the nasal septum or the turbinates, but the disease does track back along the middle turbinate to the sphenopalatine foramen, which is a favored spread pattern. So in this patient, the diagnosis of invasive fungal sinusitis is made with a high degree of confidence, and the emergent or urgent recommendation to the referring clinical team is to get an otolaryngology consult to confirm that disease by biopsy.